40 years back when I joined medicine in 1983. And since the time I was a postgraduate in medicine in Usmania, the outcomes of OHCA have not changed. 33 years back, when I was a postgraduate in Usmania, the first year, I received a bouquet from one of my patients. It was surprising. In one of the afternoons, she came and her son and them, they garlanded me and gave me a sweet box. Incidentally, in the same hospital in Usmania 33 years back, I received brickbats also when an out-of-hospital cardiac arrest subject could not be revived. Actually, in-hospital cardiac arrest subject could not be revived. Over the years, having lost a close family member from OHCA and one of my close friends from OHCA, and the disgusting certification what I have been doing as an intern, as a postgraduate, as a DM student, the certification is broad dead case. Incidentally, the experience may be the same with you also. So all these things, and even as a DM cardiologist, when I started practicing in a low resource center in my hometown, Hanamkonda, there were instances where I was called to the residences of the patients even to declare death, even the midnight also. So all these things over a period of time, probably consciously or unconsciously, made me take a lot of interest in out-of-hospital cardiac arrest, in creating awareness, do research, and teach and train lay public on OHCA. With this background, I thank the National Committee of CSI, the State Telangana Committee of CSI for giving me this opportunity now, and also for the last few years on giving 1 or 2 orations as 2 lectures and giving me the opportunity to give 3 book chapters in the CSA updates from 2020, 21, 22 and now also. So with this background, I thought on the invitation of my friend Dr. Ramchandra, I thought this would be an important topic. The reason I am presenting this as a non-invasive cardiologist, presenting on an invasive cardiology topic is, to me, it is a learning opportunity, and to the state of Telangana CSI, it's a suggestion to take out-of-hospital cardiac arrest as an important priority, both in research as well as creating community awareness on out-of-hospital cardiac arrest, creating awareness on cardiovascular disease, and start community CPR. I have reviewed these topics from American Heart Association guidelines, the SKY statement and AHA guidelines. I will be dealing with what is OHCA, the cardiac arrest centers concept, the concept of role of cath lab in OHCA management, the clinical prediction tools in OHCA, and what is the initiative before us in this. 50% of cardiovascular disease deaths are due to OHCA, and with only 10% surviving after they reach the hospital. The chain of survival concept, where early recognition, early CPR, early defibrillation, advanced resuscitation care in a ICU setting, post-resuscitation care will impact the survival of OHCA subject. And the OHCA care team, basically the pre-hospital care is the one which will impact the survival. Okay. Now, coming to the AHA recommendation, the AHA, the ILCOR, International Committee on Resuscitation, and the NHS Trust in UK, they have initiated that every cardiac arrest subject OHCA subject should be transferred to a cardiac arrest center. This is the recommendation. A cardiac arrest center is one where a comprehensive bundled care of interventional cardiology and intensivist care, target temperature management, and multimodal prognostication is important. AHA, the concept is every cardiac arrest. The one question is whether every OHCA subject who attains ROSC or in a comatose state should he be transferred to a advanced resuscitation center. There are 2 views. One, AHA, ILCOR, until recently the concept is every OHCA subject should be transferred from an initial resuscitation referral hospital to a advanced center, which could be a level 1 center or a level 2 center. This level 1 center is the one which is advanced center, and the level 2 center has got initial management. So, after this concept has come, recently in the ESC 2023, there was a paper where it is told that instead of an expedited transfer to an advanced center, it need not be. The initial management can be in a center where minimum care is available, where resuscitation can be done and minimum care is given. So the NHS has, I think the paper is from Guy's Hospital, London, that advanced immediate transfer to an advanced center need not be given. This is as per one of the trials, I think, which was submitted in the ASC 2023. So in a subject with post-cardiac arrest care, if you attend ROSC, in a comatose state or non-comatose state, initial assessment, clinical history, and all these things are very important. What we call as ABCDF, like the airway, breathing, circulation, disability assessment, the clinical examination findings, and further care. So this is the algorithm for when someone has in invasive cardiology, whether ROSC or without ROSC. Without ROSC, eCPR and other things, I think we have one of the speakers on eCPR and ECMO and other things. Whereas if he attends ROSC, if he ROSC comatose condition and ROSC who is conscious, the conscious ROSC subject would be like any other subject, what we deal in the routine clinic care. But those ROSC comatose subjects, recently in the AHA circulation it have given, so 12 lead ECG has to be done. If there is an ST elevation MI, definite cardiac care intervention management. In a non-ST elevation MI or where there is a non-shockable rhythm condition, the deferred management of angiography is indicated, and this is a protocol. So in early cath lab, it will give a knowledge of the coronary anatomy, about the hemodynamic management and ECMO management. Now this is the coronary artery disease burden in those with OHCA subjects. ROSC, significant CAD is seen in 70 to 95 subjects, and acute lesions are around 70 to 80%. Without ST elevation MI, only 25 to 30% have this, and refractory VT or VF, it is 85%. So the cath lab role in OHCA, as per the SKY statement, a decision-making method which should be based on situational awareness and assessment of all the clinical parameters should make us decide whether early cath intervention is required or deferred one. Those with an ST elevation MI, definitely cath intervention is required, and those without an ST elevation MI or a non-shockable rhythm, a deferred management is required. So this is the current guidelines based on the ERC guidelines, European Resuscitation Council and cath. These are different trials. Now, until now, all these, whether cath is indicated or not, is based on observation studies only. The DISCO, COACT, PEARL, COO, TOMAC and COACT has been published already, and other trials. These are the randomized trials on OHCA management. Refractory VT. Refractory VT is by definition with more than 3 shocks also, it is not there, and 15 to 20 minutes on successful resuscitation. The arrested trial has shown that it is a randomized trial. In this, ECMO is better compared to a standard advanced life support management. Mechanical circulatory support, again as per the arrest trial, it has shown that it is indicated, and I think we have one of the speakers on this. Now, this is the SKY statement of the cardiogenic shock management, ABCDE management. Then the clinical prediction models. Clinical prediction models in OHCA management, basically these are the differences. Cardiac arrest hospital score, OHCA score, TTM score, C-graph, CREST model. And of all these, the miracle score is the one which is very important in prognostication of a OHCA subject. These are some of the risk factors. If it is a witnessed rhythm, witnessed cardiac arrest, if it is a shockable rhythm, then other parameters, then the survival rate would be more. What we call, if it is a witnessed cardiac arrest and if it is a shockable rhythm, as per the international trials, we call it as the Utstein comparator cohort, where the survival rate would be better. Now, lastly, I was discussing with one of our senior colleagues, why we do not publish the data. Internationally also, whether the public reporting of outcomes after OHCA is important. Yes, we have to report the public report, but there is an hesitancy in reporting these outcomes of OHCA in hospital, out of hospital subject, because the survival rate would be poor. No matter the survival rate is poor, but we have to present our data so that it is a learning opportunity, so that we can improve from a 0-1. For example, in one of the studies which I published, the first registry on out of hospital cardiac arrest in India, Warangal area cardiac registry, the survival rate is 0. But when I submitted from the media reports of OHCA, the survival rate is 1%. From the existing 0%, we need to improve more and more. That is the concept of doing a study on OHCA. And even the ERC and international trials, they have given how to improve the quality management of OHCA management. These are some of the domains in which quality indicators in which management of OHCA can be improved. Ultimately, always it reminds me, translating the religious one to the technological world nowadays, the Mahamrutyunjaya mantra, if you want to loosen the noose around Markandeya and to improve the survival rate and save him from premature death, the recent or the present day out of hospital cardiac subject, I think all these people, the lay bystander, EMS personnel, medical professionals, intensivists, and all the cardiologists, electrophysiologists, pediatric cardiologists, the valvular heart disease specialists, TAVR specialists, cardiac surgeons, neurologists for neuroprognostication, anesthetists, all these Dashavataras. You may have a Lord Vishnu in the previous, for each yuga you will have one avatara, but in the present day world, in a single yuga we have all these Dashavataras to improve the survival rate of an out-of-hospital cardiac arrest subject. And it is not the medical professionals alone, it is the pre-hospital care which is very important. So ultimately, again, I would tell that as a non-invasive cardiologist practicing for the last 25 years, my aim of presenting this, we need to create awareness, research, teaching and training on OHCA. This is one which I have coined, ART program, awareness, create awareness on cardiovascular disease, create more and more opportunities for research. We have to present our data. And lastly, I would tell that I presented recently, and I thank our mentors, teachers, Dr. Dayasagar Ragharu, Dr. B.K. Shastri, and all others in the national committee who have encouraged me in presenting my research and giving these orations on OHCA. Recently, for last 25 years, we had 49 OHCA subjects brought to my clinic. In my clinic, actually, there were cardiac arrests also. I presented the survival rate, and the survival rate, of them, 15 are surviving now. The survival rate is 20% after nearly 20 years. So I thank once again the State Committee for giving me this opportunity on OHCA, and thank you so much.
Dr. Srinivas, thank you for your inspirational talk. I have one point for my own learning. Suppose a patient comes and arrests in my ER and ECG doesn't show ST elevation. What is your take on doing angiogram and hypothermia? Two things.
Yeah, that's a good question. Probably, I will only present, as I told you, I am not an interventional cardiologist, but from the literature, because of time constraint, I did not give you the details of this. Even in the non-ST elevation MI also, if it's a non-shockable rhythm also, cath lab is indicated. It all depends on the operator preference and the decision making. Because if it's a young person, because in one of the SKY statements and even the other things, it is mentioned that depending on the age, comorbidities, whether he has renal involvement, whether it's a neurological involvement earlier, I think we will defer it. But if it's a young person, and even if, see in a ST elevation MI, 80% on average will have significant CAD lesions. But even in the non-ST elevation MI and non-shockable rhythm also, 25% of them are known to have a coronary lesion. So I think based on the operator preference, individual preference, that's what the SKY statement is. Based on the decision making should be based on situational assessment. And then you have to go for these interventions.
Thank you, sir.
Thank you. And Just for information, next week I am giving a talk by the state convention and by the Indian Medical Association Telangana branch. I am giving a talk in IMA in AAG hospital, and all of you, any of you are interested, you can attend this. The topic is improving survival from out of hospital cardiac arrest, focus Telangana. Thank you.
Okay, I'm just